All right, so this is Senate Health and Welfare. We're back. And again, I'm bringing a proposal to the committee to look at and asking the committee to consider endorsing it rather than the amendment that is currently in the calendar. And we can, if you want to sign on, yes, and if not, no, then we'll go from there. Let's do our work. Okay.
Good morning, Jen Carvey from the Office of Legislative Counsel. And I get this new draft of form of the amendment that you have looked at before, because only Senator Lyons had talked to me about it. I didn't put anybody else's name on it, so you can all decide. So we're all on the prior iteration so far to Senator Lyons on this one. And so if you maybe recall from the last version of the amendment that we looked at, first, just context, this is S190. This is the Green Mountain Care Board reference-based pricing and as introduced hospital outsourcing clinical care. And so in the version that we had looked at last week that people had signed on to, we were looking at changing the cap on the qualified health plan reimbursements for hospitals. Instead of using the Medicare adjusted base rate definition that was in the bill as you originally reported out of this committee, we were going to use actual hospital specific Medicare reimbursement rate, and the rate was going to change from a 250% cap to a Medicare cap to a 225%. This amendment would go back to the earlier version of what you passed out and use the Medicare adjusted base rate. So it doesn't take out all of section 2 and put in a new section 2. It just makes a change in section 2. And so it really keeps everything in concept that was in section 2 of that cap on the QHPs at 250% of the Medicare adjusted base rate. As you passed out of this committee, the only change that I have retained here is in the first instance of amendment in the bill as it was passed out of the committee. It talked about the cap on reimbursements remaining in effect until the applicability date specified in the Green Mountain Care Board rule establishing the reference-based pricing methodology. And we had changed that in the amendment to the reimbursement limits remaining in effect unless and until the board establishes a different reference-based price. I think there was interest in continuing with that piece instead of what was in the bill as passed, instead of saying the applicability date of the board's rule, just unless and until the board changes reference-based pricing as it would otherwise relate to this cap. So that's the first instance of amendment here. The second instance of amendment keeps something you had done in the amendment that we looked at last week, which was to change the language around the hospital kind of relief valve for the caps and the reductions in commercial reimbursement rates being directed to the 250% cap for the QHPs and the rates in excess of 500% of the Medicare rate or otherwise very high. And you had, in the amendment we looked at last week, allowed a hospital to increase rates for one or more of its service lines, such as primary care, as long as in doing so, it remains compliant with its overall budget. And again, that was a piece that it would be retained in this draft. The biggest new piece here is sort of related to this, to going back to the Medicare adjusted base rate, only in the sense that that potentially has a bigger and yet unknown impact on hospital budgets. And so this language would try to give some reassurance to critical access hospitals on one piece of hospital budgets in 2027. And so I'm going to stop for a moment with the bill language itself, just to talk about an issue that I know the Green Mountain Care Board has been looking at. I know House Healthcare has been taking testimony on it. A lot of people in the room have been working on this issue, but I think it's an issue that was not on most people's radar, including mine, until recently. And that is that in Medicare, Medicare requires that that a Medicare beneficiary pay a co-insurance rate. So the amount that they're paying is a percentage, not a fixed dollar. Their co-insurance amount for outpatient services at critical access hospitals is based on the hospital's charges, the list price for the services, not the Medicare payment rate. So it's based on Medicare payment rate for other types of hospitals. But this is a larger share that can end up falling on the Medicare beneficiary. in
It's
critical
based on
access.
outpatient what?
It's based on the charges.
Total charges.
But based on the charges for the services, not the negotiated Medicare, not really negotiated with Medicare, but not the rate that Medicare pays. Am I getting this right?
Yes.
Yeah.
Correct. It shifts the burden onto the patient, and sometimes they end up paying away from
So
Medicare.
the patient is saying this extra charge.
Patients
Based
get a
on
lot
this
more,
whole-
and there's no cap on what the patient can pay, unlike, again, for prospective payment service hospitals, it's 20% of the Medicare payment amount, and there's a cap. For critical access hospitals, this is all federal law, so this is not something Vermont did, like all federal law. And I believe there are recommendations to the federal government to make changes to it as well. But there's been a lot of attention brought to this issue and being paid to this issue as people are understanding it, although it has been in place for a long time. So back now to the amendment. This amendment directs the Green Mountain Care Board to convene a working group with representatives of the board, Department of Vermont Health Access, Department of Financial Regulation, representatives of critical access hospitals, of health insurers offering Medicare supplement insurance policies. Those are the Medigap policies, because for people who have Medicare supplement insurance, that helps with their out-of-pocket responsibility. So this is falling in part on Medicare supplement plans, and representative of the Office of the Healthcare Advocate. And this working group will develop recommendations for ways to mitigate the effects of a federal requirement that Medicare beneficiaries bear financial responsibility for 20% of the amount charged for outpatient services delivered by critical access hospitals. And it would have the board provide the working group's recommendations by January 15th, 2027, including the projected impact of each recommendation on patients, critical access hospitals, and premiums for Medicare supplement insurance policies and the state budget to this committee and finance committee because of the Medicare supplement piece and others. And then it prohibits the Green Mountain Care Board from addressing or attempting to address the effects of this Medicare cost sharing requirement through the board's hospital budget review authority in fiscal year 2027 hospital budgets. So this is looking to provide some assurance to critical access hospitals that as you're moving all of these other levers related to the amount that they get paid for services, that this is one that will not be, the board will not use to address this Medicare cost sharing issue through critical access hospital budgets in hospital fiscal year 2027.
So, and it's my understanding that there are other ways to handle this than through the budget. So,
And through hospital budgets.
yeah,
I mean, I think the working group has to look into what
Look
those
into
are,
that.
but yes, we certainly, there could be state money provided, there could be,
an appropriation.
right, there could be appropriation, there could be other ways of listing charges or rates. Refer to the working group to figure out what that is.
Got it.
But this is saying the solution, at least in the short term, is not simply to tell hospitals they can no longer collect this,
And it's just for the one
just for the one
budget decision in
yes.
October.
Right.
Okay.
And that's it. And then we renumber, I made that section 11. So toward the end of the bill, and then renumbering the effective date section to be section 12.
So we're keeping some of the language that we had in the initial proposal and the amendment that's in the calendar. That would be section C and the two section Cs, first and second.
Right, the sections, right. So that, yes, those are two pieces of your amendment, but otherwise keeping the underlying
250
bill
for
that
the
you,
QHPs.
yes, based on the Medicare adjusted base rate.
Right. And just, okay, and then the other is the working group, so that understood hospitals are concerned, and needing reassurance about taking another step within the current budget process that might be a straw.
And you may want to hear
Yeah.
from them about that.
I really appreciate the work in this. This is really good. Thank you very much. I will do whatever it takes to move things along, but I just want to say I'm very uncomfortable with telling the Greenmount Board, the care board, what to do. They're our regulator. We should let them regulate, and I don't like that I don't like that little B at the end of this. And I just don't understand why it's our role assurance to the critical care hospital. So, I mean, it's a nice thing to do, but I'm just struggling with that.
Understood. I know it feels very uncomfortable to have the board to be prescriptive to a regulatory board. Completely understand that. So any other questions or comments? I might go outside the table for just a brief minute to hear folks around the room. My enthusiasm for this actually is about having the 250 back in place and knowing that there's going to be a level playing field and that we could actually see some savings through our quality health plan premiums for patients, our small businesses, our individual groups, so our individuals. So why don't we listen to folks? We have a little bit of time. Short comments would be helpful. I see everybody in the room, and I'm assuming everyone in the room has a comment to make. We posted it earlier, and I know you've seen it.
You want people to come up here? You want me to go?
No, I want people right there. I want you right there. So, healthcare advocate Mike
I'll
Fisher.
start and then Debbie can push back. Mike Fisher. I appreciate the move back to base Medicare, and I appreciate the 250. Those are good changes. I am troubled by the Medicare cost sharing language.
Language.
Medicare cost sharing language. I get it that we can't ask the hospitals to do everything. I get it that we have to be really careful about the amount of pressure we put on hospitals. The status quo stinks. We think it's about $30 million that are being overcharged to Vermont's rural seniors and disabled Vermonters. And it's not money going to the hospitals, it's money going to the federal government.
Right.
We think it's about 11% of the Medigap plans, of Blue Cross's Medigap plans that are related to this overcharging. And I'm sure that hospitals, so just to say it again, the hospital only gets what Medicare allows. So this is not about excess money going to the hospitals. It's about how much of that money comes out of someone's pocket or their secondary payer and how much comes from Medicare. And so I don't know whether we can do anything actively in this budget cycle. But I sure don't want to rope that off. I want to keep pushing and about the working group, fine. We had a working group in effect 2 days ago. And I think there's a lot more work that needs to happen. It might not have felt like a working group because the board can't meet in any way other than in an officially warned meeting. But I think that the people were pulled together and they were asked to bring their seat up to the table, and many critical access hospitals did and expressed an interest in that. And I'll just say related, not exactly the same, but I just want to say it out loud. We think that this also affects Medicaid food stamp dollars here, and maybe more than $10 million.
Okay.
Yeah.
Understood. We hear you. Anyone else would like to comment?
Yeah, that's my cue.
I'm gonna go right down the line.
Devin Green, Vermont Association of Hospitals and Health Systems. First, I want to thank the chair for putting the critical access hospital cost sharing piece in. We are committed to working on that problem. And we think a work group is an appropriate way to do it. I will say that the Green Mountain Care Board does have other options besides public meetings. In the past, they've had working groups on certificate of need. They've had working groups on site neutral, that were not official board meetings. And so I would hope that that's a process that we can use going forward. But we agree that this is a problem. We don't think the hospital budget process is the right way to solve it. You have asked us to cut our administrative positions. We have done that. We are very lean on resources. You're asking us to do a very big thing with the 250%. And we agree that something needs to happen on affordability, and we are working on it. We want to do the 250%, but our hospitals are at a point where we can only do one big thing at a time, especially the critical access hospitals. So what this tells us is that the 250% is the priority for right now. And in the meantime, we will continue working on this federal issue as opposed to taking funding from the critical access hospitals to address this federal problem.
I understand that, federal government, Jen, correct me if I'm wrong, federal government is also looking to repeal this provision.
I don't know that that's true. It's the
No.
MedPAC that
Okay.
advises, has raised this and recommended changing it, but I'm not aware, and others may have a greater sense of where things are federally, but I'm not aware of any active proposals to.
And the federal government works so quickly, we can expect it to. All right, so thank you, hospitals. I'm gonna go to her in a minute. And, so your concern is having to address both of these things at the same time. And I will just say, we hear your concern. We also hear the concern about, all this money going to federal government. Doesn't sound great. I will also understand that this bill is moving from the Senate to the House Healthcare. So there is time for a broader consideration. I agree with Senator Buick. I don't like putting in language that ties the hands of our regulatory board. That's problematic. However, under the situation that we're in and hearing the concerns for our smaller hospitals, I think it's reassurance, and it is time limited. It's for one budget year. This would happen regardless of anything. It came up at the tippy end of what we're talking about. And so if the board decided to do everything all at once, we would see a lot of our hospitals without their reserve funds and their inability to continue. So I'll stick with it for now and listen to the Green Mountain Care Board.
Yeah, thank you. So first, Elena Barabee, Director of Policy at Green Mountain Care Board. I think I've echoed a lot of what we heard from the healthcare advocate. This is a really big issue for some of our most vulnerable seniors. Again, the MedPAC recommendation even highlighted the issue here is not how much hospitals are getting paid. Any solution can and should keep hospitals whole. The issue is that with this charge rule, our most vulnerable seniors are paying sometimes more than what the hospital's bringing in. We're actually sending money back to the federal government in some of the most egregious cases. And that happens around 4% of the time. So you're asking our most vulnerable Vermonters to pay some of the highest prices in the state and pay the whole bill.
And right now, are those fees in place?
Yes, those are in place all over the state.
Yeah.
It will not be addressed by the reference-based pricing issue because the charges will be untouched. Again, this is not about reducing hospital revenues. This is about making sure that Medicare is paying their fair share and that we're not, driving higher burden on some of our most vulnerable patients.
So it becomes, as you're speaking, there's clarity here that the QHP and this rule provision are two separate organisms, two different things. QHP is one that we're really supportive going forward on. I'm hearing that. And this one over here is something that has come up and that folks are concerned about. It could, my question for you, and it's probably for the board and for hospitals. What kind of administrative actions would be needed and how much would be needed in order to undo the effect of the medical care pricing in the
I
hospital
think that's
budget process?
where we agree that we need to work together collaboratively to really detail out the impact of these various solutions and work together to find the best solution.
Okay, so there is a need for some kind of a little working process there.
Yes.
So that's the group.
Yes.
Yeah, okay.
So the one piece I do want to clarify, about at least about how the language reads currently is that it prohibits it prohibits the board from using its hospital budget authority. It doesn't say nobody can work on coming up with solutions. I think it's sort of, it's effectively saying it wouldn't happen in a unilateral way.
In October. It's
Yes.
not gonna change the budget
Yes.
this year to do it, but there could be another proposal that could help. They might ask us for money. That's the other problem right there, Okay. All right. Thank you. Clarity is helping. Okay. Senator.
I have a question, just my experience with the Green Mountain Care Board is relatively limited, as is my time in the Senate. So wondering, is the setting of any kind of a precedent to be telling the board to not do this thing that they've been in statute, they've been sort of told to do? I'm just wondering if this is a weird precedent for us to be setting.
I guess I'm not clear what you mean they're told in statute to do. It's telling them
They're the regulator, right? The hospital regulator. And now we're saying, actually, wait, we're putting some restraints on your ability to regulate.
I mean, I think what you're hearing about as a description of the issue is that it's not really, it has a solution, I think, has the potential to affect a hospital budget, but I don't think it's necessarily restraining their ability to develop hospital budgets that comply with statutory requirements. It's effectively saying not to use a piece of regulatory authority to address an issue that affects individuals. I'm hearing behind me that may not be.
Well, and I'm not the lawyer, so you should have another opinion from the board. Elena Barabee, Green Mountain Care Board. I think we have a broad obligation and duty to improve affordability of healthcare in our state. And I think that is part of the budget process as much as guidance and benchmarks and these very discrete things are. So the board does not agree with the language that restricts its ability to act. So I think we do agree with, developing a robust understanding of the issue, which we've been doing, as you've heard. There's still more details we need from hospitals to understand that particular impact of these different solutions. But we do not feel like we should jump ahead and say, don't do anything about it. If there's something worth doing, we should leave the door open to do it.
So what is in here is don't do this within the 27 budget. But there's nothing that precludes the board from making a recommendation for the 28 budget. And there's nothing that precludes the board from finding an alternative solution.
I think if there's a solution that we find this year could provide relief and for millions of dollars to Vermonters,
Mhm.
We ought to take it.
Okay, and then I'm gonna go right over to Boz, and then we'll come back to Senator Cummings, because I'm going to hear something about the administration of that solution. I don't know. You want to hear?
Devin Green from Buzz, if that relief comes, if that millions of dollars of relief is in the budget process, it's coming from our hospitals.
Or Medicare. We don't know that. It could come from Medicare.
Okay, so.
But I'm, again, if it's in the budget process, it's coming from our hospitals. I don't think, what we have heard from the Green Mountain Care Board is we are going to put something in your budget guidance, which is due at the end of the month, on this issue. And it's been very vague about what that is. It's been very hard to plan our budgets around that. So if we have something in the budget guidance that just says, we're going to do something to your budgets about this issue, we have a very difficult time planning going forward. And so that is why we're asking for this clarity right now.
Understood. Okay. Senator Cummings. I'm trying to wrap my head around this. This is essentially a copay that you go in, you have a procedure, the hospital sets the copay. No,
Now, well, you set the charge.
you
that
set
the
the
copay is
charge.
based off of.
So Medicare only pays X amount. You set the charge, but under this, the individual person has to pay the difference between,
Medicare pays the difference after the copay. So if 20% of the charges is more than what Medicare pays, Medicare doesn't pay anything. Patients pay everything and more. It is incomprehensible. I
I have good supplemental insurance.
and then it goes to supplemental
That's,
insurance.
I don't
So
even
you-
have to deal with this.
Yeah,
Okay.
but
Well,
you're-
they do.
Well,
Your premiums, if someone's paying for it.
Your supplemental insurance
I
is
have
more
paid a
expensive.
lot for it. I think my social security checks.
Especially if you're going to critical access hospital. This is how, right?
Okay. So there is a charge and that the hospital sets on service. I go in. I pay a copay that is set by,
20% of the charge.
it's okay, so
Sure.
I pay the copay that is 20% of your $2,000 charge.
So.
But that's a Medicare requirement, just.
That's a
It's a
Medicare requirement, right? Medicare says you gotta pay the 20% of the
Of the
charge. But if that 20% of the charge, if the charge is high enough,
500%.
okay, then Medicare pays nothing because my copay has
That's
covered what Medicare would pay. So I'm paying, Medicare is getting off the hook for paying anything. And the hospital is ending up with the same amount of money.
Or we have our financial assistance policy and we're covering it with that.
From me.
If you
Or-
can't pay,
Or it goes to bad debt. So there's also a scenario where this is, where this is a loss for hospitals.
right?
So if we
Yes.
can address the patient cost share, you're actually providing financial relief to hospitals.
Right. No one
have
likes
that.
this policy. We want to address it. We don't think the budget is the right place to address it for this year if we are doing this major shift to revenue-based pricing.
Be part of the study, right?
Yeah, you can.
Right.
Senator, I'm gonna have you describe it on the floor.
You're doing so good.
Can I draw a diagram?
Yeah.
Yeah. I've got it. No, so it's, how long has this provision been in place?
Decades.
It's
Yeah.
ancient history, isn't
Yes.
it? And it's, so it just sort of bubbled to the surface.
Well, it's been made worse and apparent through skyrocketing charges. When
Yeah.
charges were lower and reasonable,
Yeah.
close to cost, this wasn't an issue. Now our charges are sometimes upwards of 11 times
Exactly.
the cost. So, and that money beyond is what, patients are still paying that 20% of 11 times.
Okay, and then private insurance is also paid.
Yes, and Medicaid.
And Medicaid. But our hospitals are still not financially. no.
Well, but they don't get to keep it.
They don't get to keep it.
It goes back to Medicare.
Well, they charge me and
When we overpay, the difference goes back to Medicare. Hospitals receive the same thing no matter what. We are subsidizing the federal
Okay.
government by
we don't want to
overpaying.
do that.
No,
We don't like they don't charge
subsidizing
the
the
federal
federal
government. The hospitals don't like it.
No, no
The
one likes that
healthcare
policy.
advocate doesn't like it, but we don't like it. Our
Private
goal here
insurance is
is to
paid.
ensure that as our critical access
I mean,
hospitals
if you want
go
to
through the
paid somewhere,
then
We are-
40% are.
We are getting paid our reimbursement.
Senator
amount.
Cummings.
If it's more than that, it goes to Medicare.
Right, but no, private insurance, absolutely.
Medicaid.
That- Get. And one of those
Commercial.
ERISA.
Yes. So what we're worried about with the ERISA piece is
Yeah.
if we change, if through the hospital budget process, they change your charges,
Okay.
the ERISA plans they will follow the charges that are now at the Medicare level, and that will devastate our hospital.
Okay. Okay, so I was in the middle of a sentence, but it was a better conversation. I get it. I understand.
Sorry.
I do
they
want
need it for the bill that's.
I want to say one thing because I really do take seriously the effect that that last paragraph has. I don't think any of us like telling the board what they can't do. We were not going to extend this. This is a one-time deal, honestly, and Senator Gulick has brought that issue up, and I think we need to be very clear that the board has to have that regulatory authority. We're, as we've said before, we're in this very strange transitional time when there's a lot of upheaval and imbalance in the affordability discussion, the money from hospitals, critical access hospitals and others. We know there's a delicate balance with our insurers. We know there's a delicate balance with our policyholders. This is a one-time deal. If that little section stays in where it shall happen only for the 27 budget, only for that 27. Have I said that clearly? Anyway, that's what the proposal is. I don't use a critical access hospital. I use the large academic medical center. And a lot of people do use the little hospitals across the state. Some people use Rutland or Southwest or Northwest. They use the larger hospitals so that they're not affected. But there's certainly enough folks who are affected by this, and those hospitals disappearing or having concerns would be problematic. So, well, there we are. So, committee comments, questions, further discussion, folks you'd like to hear from here sitting around. Senator Bueller.
Well, I think Senator, she didn't raise her hand, but I sense. No,
I'm fine.
okay.
Are you?
I again appreciate this work. I will not be signing on just because we've talked so much about trust in this room and this session. And I do think that last paragraph is not affording the trust that we need to have in our regulator. So that's
That's fine.
I'm okay.
Do you want to sign on?
Sure.
Okay. So, really gonna make me explain?
Yeah. I was hanging on your every
We have
word.
questions.
Well, it's a charge that goes to patients that if it's not covered by Medicare, it's an excess. It's paid out of the patient pocket. And, so it's the hospital charge.
Yeah,
That's
but the
key here.
patient pays first.
Yeah, patient
And
pays
if the
first.
patient's 20% is equal to or greater than what Medicare would have paid, Medicare pays nothing.
Right.
So in this case, usually your insurance pays first and you pay the difference. In this case, you pay first. And if there's no difference, the insurer doesn't pay.
But I agree with that. That's what, okay, I just want to make sure she's had it right. That's what I,
That's my.
It's like an out of pocket before anything else happens.
But can you
Out
add
of pocket or
to your,
secondary,
Huh?
out of pocket or secondary pay.
Yeah.
This
Yeah, right.
affects employers, it affects individuals, it affects Medicaid, it affects.
Yeah.
And
Yes. So I understand your hesitation, Sandra, and appreciate your comments. All right. So this has been fun. So I will take it upstairs. I know there will be questions on the floor about undermining the board authority. That's to be understood. This has a pathway forward. I did talk with the chair of the board last night, and he shared the concerns that Elena, you have shared. And that it would be important to him that the board be consistent with state law, and there's language in there that would literally undermine the provision as written, so I understand. What we don't want our board to fail. We don't want our hospitals to fail. This is a one-time deal and it's for 27. And we do make exceptions to the rule from time to time. It does offer reassurance. The trust that we need to engage with this is with the hospitals. Don't come back to this.
Understood.
Okay, so any other things you'd like to do today? What happened in y'all?
So we're,
The budget is on the hospital.
we canceled the budget. Don was not available today. He's busy with the.
That's what all the budgets are. Thank you, Jen.
Yes, just adding